Hello and welcome to the Retina Radar. I'm Arshad Khanani, Managing Partner, Director of Clinical Research and Director of Fellowship at CRI Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. Today, I'm joined by my friend and colleague, Dr. Carl Danzig, Director of Vitreoretinal Services and Retina Research at the Rand Eye Institute in Deerfield Beach, Florida, and Affiliate Assistant Professor of Clinical Biomedical Science at the Charles E. Smith College of Medicine, Boca Raton, Florida. Welcome, Carl.
Great being here, Arshad. Thanks for having me.
I have known each other for a really long time. I think 16 years plus. You were my junior fellow, and I'm so impressed to see what you have achieved in the last, 13 or so years in your practice. And I'm excited to talk to you because you're involved with all the latest innovation in retina. So today we'll be discussing current and emerging treatment options and real-world studies regarding the management of patients with DR and DME. And obviously, the focus today, Carl, with you is non-invasive treatments for DR and DME, which is a big unmet need. Before we get started, we have few questions about our faculty members that we ask for all of our guest faculty that join us. So let's get started, Carl. Tell us, how did you end up in retina and becoming a retinal specialist?
Great starting question. Well, first, I want to start off by saying that when we were fellows together, who would have thought that we would have ended up doing this together years later, collaborating, furthering medicine, advancing innovation, and helping our patients? So that's really what it's all about in the end. And I end up in retina because I want to be at that point, that juncture when patients really need the help. They're anxious, they're afraid, they're losing their vision. And much like a lot of us in our field, I want to be there to help intervene at that moment. But the thing I like about retina, because a lot of things in medicine, you can intervene and make a big difference. But I love the innovation in retina. I love the collaboration. And I love how we, as a specialty, and not a huge specialty, can really impact how medicine is delivered throughout the world. And I love that about retina specifically. I love the innovation. I love the tools, I love the toys, I love the surgery, but it's really that collaboration that we have together that, furthers the field. And I really love that aspect of it.
No, I agree with you. I think it's such a small community, and we are making big impact for patients around the world and preserving vision and helping them having better lives and independence. And I think it's clearly such a rewarding field for us. And again, great to work with you in so many things that we do together. What about your favorite hobby? A little bit about Carl Danzig. Tell us, what is your favorite hobby?
Well, I'm originally from Philadelphia, so cheering on all of my childhood sports teams is a big hobby of mine, and I'm excited for football season to start and for baseball season to really enter into the playoffs. But probably my favorite thing to do would be to travel. I've traveled extensively. I've been very fortunate to do that. Most of it has been on a very strict budget prior to finishing fellowship and being in attending. But one of my biggest achievements, I think, in my personal travel career is I have been able to see all 7 new wonders prior to having prior to starting a family with my wife. And I have also made it to the one ancient wonder that still exists.
Oh wow, that is impressive for sure. So, uh, takes us to our next question. What's your favorite vacation spot?
I think I'm happiest, well, internationally, I'm happiest in Southeast Asia with a few dollars in my pocket, a little red stool, and a steamy hot soup in swampy weather. And I'm pretty happy.
I like that. Okay, so let's get to our topic at hand. How do you look at the treatment options for DR and DME currently, and what falls short in terms of patients' outcomes, and what gap do you see that non-invasive treatments might fill in our clinical practice?
So currently in the space of DR treatment, there is an unmet need for a non-invasive treatment because all we have right now are observation and diabetic control or intravitreal injections. Now, we know that the retinopathy with injections can improve, but the perfusion may not, or the lack thereof. And if the patient starts missing their appointments and it's hard to keep up with injections, then the retinopathy comes back and can get worse over time. So there's a unmet need for a treatment other than an injection in the eye. In terms of DME, again, it's injections in the eye. And we have really fantastic treatments for diabetic macular edema with some longer acting regimens available now that are FDA approved. But nevertheless, not everyone responds and not everyone can keep up with the treatment regimen because diabetic patients commonly are working class and they need so many doctor appointments throughout the month. They don't just see the retina specialist, they go to the nephrologist, endocrinologist, dentist, podiatrist, cardiologist. And that's only some of the doctors they may go to. They may have other medical problems that they have to visit those doctors too. So there's so many days of missed work because they're at the doctor that they can't keep up with these appointments. And we need ways to fill in the gaps so the patients continue to thrive in their life, see better, and not miss treatments.
I think those are excellent points. I mean, as you said, we are lucky to have great options, but they come with a big treatment burden and obviously the non-compliance in the real world. Obviously, you're making some strides in invasive treatment options that are less frequent. We saw the data from the Pagoda study in DME and Pavilion study in DR with the port delivery system. Obviously, that's a surgical implant that's placed in the eye. So can decrease treatment burden, but there's risk and benefits associated with that. We have promising data from suprachoroidal one-time gene therapy with RGX-314. We are seeing some long-term stabilization and involving data there. But I agree with you. I think every time a patient comes in with DRI and DME, the first question they ask, can I have a pill and can I have a drop for this? Because obviously these are younger patients, they're working patients, and frequent treatment, especially in case of DR when they have good visual acuity initially, is very, very difficult. So in terms of all the latest and greatest things you're involved with, Carl, and the latest data you have seen, what recent innovations in non-invasive treatment for DR and DME do you find most promising and why? And then obviously we're going to jump into some specific ones later in this podcast.
Well, I've been in a bunch of clinical trials in this space myself. And, one of the biggest reasons why people want to go into these trials is because it affords them an option to keep needles away from their eye. Now, as we know, injections can be very efficacious and somewhat durable and safe. But anytime you put a needle in the eye, there's always a baseline risk of endophthalmitis or retinal detachment, and plus just the general anxiety that goes along with it or possible corneal abrasion. So they want something else. And I'm excited that, we were able to offer numerous clinical trials in our practice. And the one that we did that our patients liked a lot was the RZ402. We did that clinical trial, and our patients, they definitely were happy to enroll in that. The biggest challenge you have in these non-invasive treatments is you take the treatment away from the physician. So when the patient gets an injection, we know they get that medicine into the eyeball. When the burden's on the patient, it definitely requires compliance that we're not used to as retina physicians. We're just not, glaucoma physicians are always used to the compliance aspect for patients delivering their own medicine. Here, we're the ones usually delivering it, but now we're trying to shift that paradigm because the patients want that. They want that ability to not have an injection in their eye, but there's also a responsibility that goes along with it. And we saw that in our clinical trials too, that, some patients took the medicine more regularly than others because you would get the pill bottles back and there would be, a little few too many pills left over than were given, and knowing that they must not have taken it for a whole month. So that's definitely one of the challenges. But in the end, the vast majority of patients were very excited about the trials that we did.
I think those are excellent point, Carl. Like, patient compliance is a huge issue with non-invasive treatment because patients are responsible for it and how we can get them to be compliant. I think that's an important education tool. And I think that's why it's great to have invasive options, and it's going to be great to have hopefully future non-invasive options. I mean, the more tools in our toolbox, then we can cater, our treatment based on a discussion with the patient about what their preference is, and then we can go from there. So I think it's exciting to have all this innovation happening in invasive treatments as well as non-invasive treatments. So you mentioned RZ402. It's an emerging therapy for DMEs, a plasma kallikrein oral inhibitor for DME. Can you share with us some of the recent top line data that was released for that program? And obviously, we were also part of this study, and I agree with you. I think patients were very happy just taking a pill instead of getting injections. So give us a little bit detail on that data from RZ402 trial.
Absolutely, Arshad. The first question we get when a patient, is interested in a clinical trial with an oral therapy is it safe? And what we saw with the RZ402 was that it had an excellent safety profile. There was no adverse event regarding kidney function or liver or heart function. And that's always the first question you get. It's like, is this pill going to affect my other medicines I take? And is it going to make anything else worse in my body? So we found like that data was very clean and very good in this trial, but it also met its endpoint with macular edema (CST) change, and the CST improved significantly in all doses of RZ402. And the sub-analysis by DME severity of when you looked at patients that had greater than or equal to 400 microns, indicated improvement of approximately 75 microns at the 200 milligram dose. So that might be the sweet spot, and we're looking forward to the next step with this molecule.
Yeah, I agree with you. I think the data is the first time we have actually seen data in DME for an oral pill actually showing improvement in anatomy. So obviously, that's an important milestone. So something to investigate further in future trials, maybe a larger phase 2B to try to see, what outcomes we get. Obviously, in these trials with the non-invasive treatment, the control arm is obviously placebo, right? Because you're not going to compare it to injectables, because I think number one is going to be a high bar. Number two, it's going to lose the purpose of patients being in this trial, that they're looking for non-invasive treatment. So let's move on to another interesting program, OCS-01, which you are also closely involved with, and that's an eye drop for DME. It's interesting that many specialists, especially glaucoma, is going away from eye drops to surgery. In retina, we're going from invasive approaches to non-invasive approaches, and partly because of the patient compliance and patient's need. So OCS-01 is an eye drop for DME. It's now in phase 3 in 2 global studies. So can you tell us a little bit about the data from, well, first tell us a little bit about what OCS-01 is, and then data from the stage 1 of the Diamond phase 2/3 study, and then what to expect from this program in the future.
So this is a very exciting trial that's ongoing, and it really hopefully will really bring a new way of delivering treatment for DME. So with OCS-01, it's a novel high concentration, 15 milligrams per mil, topical formulation of dexamethasone. And people are like, well, don't we already have steroid eye drops? And though we do have steroid eye drops, this is a type of formulation that has greater penetration to the posterior chamber to really treat that DME. And what we saw in the phase 2, what we saw in the phase 2/3 Diamond study was that at 6 weeks, a mean gain of more than 7 letters was achieved in the OCS-01 group and maintained throughout the duration of the study. Now, remember, the control arm was sham here. There was also a 16 micron reduction in central retinal thickness that was achieved at 2 weeks, and this was maintained throughout the duration of the study. Of note, this is steroid eye drops. So the first question people have is, well, what's the IOP risk? Do people develop glaucoma? Well, there was a 15% IOP increase, but there were no unexpected AEs reported. And 15% IOP increase certainly is not out of line with other steroid eye drops that we use in the clinical setting.
By sham, you mean placebo eye drops, right?
Yes, I meant, yes, placebo eye drops. Yes.
Yes. So, I was part of this study and I was the masked PI for this. And I'll tell you, there are a couple of things I noticed in this study. Number one, the CST improvement, I clearly noticed that, but I was masked, but it was pretty obvious some patients were improving significantly. And then number two, Carl, was the fact that that effect starts to happen pretty quickly. So as you said, I mean, 60 micron reduction in central thickness, and then it was achieved very quickly in the first few weeks. So I think, we don't see that with other steroid eye drops. I think this technology, the Opti-Reach technology that they have really gets eye drops to the back of the eye. So tell us the phase 3 program. So Diamond 1 and Diamond 2 are global studies that are currently enrolling, and those are 1 year primary endpoint, correct?
Yes.
So yeah, I mean, we'll see what the data shows in terms of longer duration, in terms of efficacy, in terms of safety, and in terms of the trials meeting the endpoint in terms of superiority, because they're being compared with placebo eye drops, so it has to be superior. Moving on to DR, Carl, obviously, most physicians, as you said, don't treat DR because of invasive nature of anti-VEGF injections, even though they work great. As a field, we have had many failures in the past looking at pills for diabetic retinopathy. APX 3330 is, was evaluated in a phase 2 study, and planning is being done for a phase 3 trial, which will be great. Tell us a little bit about APX 3330 and some of the latest data.
Well, you're absolutely right about the failures in the past, not just with oral, but even subcutaneous treatment. But with APX 3330, it's a small molecule inhibitor of REF1. It's an oral treatment. So this was a trial that's looking at DRSS scores in patients that did not have DME. And the Zeta 1 trial for APX 3330 demonstrated a favorable systemic safety profile. Again, that's important for these patients taking oral therapies. They're on a whole lot of other medications, and showed very good safety tolerability, which could prevent disease progression or delay, further progression in NPDR patients. And what they saw was a reduction from baseline in binocular greater than or equal to 3-step worsening of DRSS score. Remember, it's an oral therapy, so they were looking at both eyes, and 15.2% of placebo subjects were worsening. They had that 3-step worsening, whereas only 5.7% of the APX 3330 subjects worsened. And there was a reduction of binocular 4-step worsening, where 0% of the APX 3330 subjects worsened 4 steps, where where it was 15.2% of the placebo subjects worsened, the same as with 3-step worsening. So those who worsened 3 steps really worsened more than that. And in the end, this could be a great option for patients in terms of maintaining the level of retinopathy, not allowing these patients to progress further, because progression to from NPDR to PDR is disastrous for patients' vision, not just their central vision, their peripheral vision, their whole lifestyle. And I'm actually curious, because we know how this molecule was safe in the trial. I'm curious on if there are any benefits elsewhere. If it's helping the retina microvasculature, could it help anywhere else in the body? Could it help maintain disease progression in other parts? It's too early to tell, but right now I'm very optimistic on its ability to help the retina and help our diabetic patients more than what we currently have available.
That's a great summary, Carl. Very nice overview. And I think one thing about this trial that stood out for me, obviously, is the fact that, yes, the trial did not meet the primary endpoint of 2-step improvements, right? And that's the standard approval pathway for any program. But since it's a systemic drug, as you said, it can affect and impact both eyes. So this endpoint, the new endpoints that would be acceptable in terms of 3-step worsening on a binocular scale by the regulatory agency is an interesting one, because I think as physicians our goal is not to make pictures look better, but rather patients don't have vision threatening complications like you were mentioning. So, and that's what leads to vision loss. So the hope is that if you have a pill that can stabilize the disease and patients don't get worse or majority don't get worse, I think that would be a big deal in terms of management of these patients with diabetic eye disease, diabetic retinopathy that currently we're just observing for them to get worse. A great overview, Carl, for all the programs. Let's say some of these make it to the finish line. How do you anticipate the real world application of these non-invasive treatments? Are they first line treatments? Are they combo treatments? Are they for the as a last resort? What do you think?
So I definitely think that for many patients, they will want this as first line because patients aren't raising their hand for injections in the eye. And that can always be used if they don't succeed or cannot keep up with treatment. But knowing that there's a possibility of injection might motivate them to be more compliant. Nevertheless, for these oral therapies, you might have to start getting the PCPs involved a little bit more than you would do with an injection. So that's definitely one aspect that we're going to have to kind of figure out how we're going to incorporate it because there's certain aspects of clinic flow and collaboration with the PCPs, making sure that they agree with it because a lot of our patients are very educated. They're becoming more and more educated every year, and they're going to want to incorporate other physicians who are caring for their diabetes also. So I think that we need to look into that aspect.
No, I think that's important. And I think, as you said, safety for an oral agent is super important because in busy clinics, we don't have time to manage the side effects. But clearly for DME, as you said, OCS01 can be first line treatment for early disease because many of those patients are currently not being treated because they don't want invasive treatments, even though they work really good. Carl, that was excellent discussion about the topic at hand, which was non-invasive treatments for DR and DME. Now let's close this with some personal questions for you. You have had a great career so far. You're kind of mid-career like me. What is your greatest achievement to date that you're most proud of?
Being your friend,
Oh, you're so nice. It's been great to have you as a friend too, and we learn from each other. Those late evening calls, your drive to work or drive from work, and my drive to work in the morning or some weekends. So no, it's been great. But really, tell me, what are you very proud of? You have a beautiful family and everything else. But I think what I see is that you have essentially taken your practice where you're only retina specialist to a new level. I think you should be very proud of that. When I look at what you have done essentially by yourself, of course, your partners help, but you're the only retina doc and you have made a world renowned research center. I think you should be really proud of that.
I'm incredibly proud of that. What we've achieved at Rand Eye, taking retina from ground zero, where we started the retina department with me and started clinical trials in the retina space, and really became a major player in this in retina research, has been a huge a source of pride for me. It is my favorite aspect of my career is the clinical research, more than anything else I do. I think it also sets a great example for other retina specialists as they start their career. But most importantly, and I'm sure you feel the same way too, is it sets a great example for our young families, showing our children that not only does hard work pay off in helping society, helping patients. My kids see that daddy has homework almost every single night in addition to their homework. And, I'm just so proud of, what I can do for my patients and also show my family that, I can help make the world better.
No, I mean, I completely agree with you, and you have done a great job there. And then, obviously you are far away from retirement, but how do you want to be remembered once you're retired?
Great question. Well, I certainly hope I'm far away from retiring because I really do enjoy what I'm doing. I want to be remembered for my hard work. I want to be remembered for my tenacity, that I don't give up easily. I don't take the answer no easily. And I always strive to do better. I want people to remember me for making an impact in the field uh, and a space where nothing has necessarily come super easy. And it's because of hard work and collaboration. And I want people to understand that it's teamwork and networking and friendship that makes everyone better, that none of us can do it on our own. And I couldn't do it without friends such as you and many others in the field. So, because of that, I want to help raise other people, and hopefully they can remember what I've given back to them too.
I agree with you. I think, one thing I really like about you is that you collaborate, you're available, you work hard, and you don't take no for an answer, but you also learn. And if somebody gives you criticism, next time you improve and you prepare. I think that's one thing that's very special about you, Carl, that you work really hard to get ready for whatever you're doing, whether it's your podium presentation, whether it's your podcast like this, everything you do, you are prepared and ready to go. And I think you remind me of the athletes, you come to the game very ready. You don't just wing it, you actually work hard to get there. So no, I'm very proud of all the achievements you have had, and there's a lot more to come in the future. Carl, thank you for the excellent discussion. And I want to thank our audience for listening in. Please remember to take the post-test and evaluation to receive CME credit and to tune in for additional episodes within the podcast series. Thanks again, Carl.
Thanks for having me, Arshad. Great chatting with you.